morning. Welcome to tonight. I am Sarah Jane, one of the co-chairs of the South East Coast Regional Network. We're thrilled to have so many of you on the call with us again tonight. I'm handing over to my colleague, Nikki Walker, to introduce tonight's session.
Good evening, everybody. Again, thanks for coming, and hopefully you'll find this session really, really useful. So the South East Coast Regional Network is a committee of physios across the NHS and private sector around the South East. So the aim is to connect with others, connect at a local level, and give you some virtual and in-person events that you can follow to keep you up to date with what's going on in our area. So this is our second webinar in the series. And this is about how you might tackle musculoskeletal questions when you have them asked of you when you're in an interview. Now, we're really lucky that we've got a couple of really, really well-experienced clinicians who can answer some questions for you as well, and give you lots of detail and give you lots of hints. This is going to be recorded, so hopefully there'll be something that you can replay when if you do get an interview, you can replay it and it will be useful. And there will be question and answers, so myself and one of the other speakers are going to just manage the questions. So do put things in the chat if you have questions, and then we'll try and answer them as we go. Having done lots of interviews myself during my career and having done interviews for other people, there's one thing that we were just talking about as a group, which we thought might be useful to say initially. So when you have a question in front of you, a lot of the questions that you'll be asked will be point scored questions, because it's very difficult to differentiate between lots of different people who've got similar experience levels. So think about drawing a picture. So if you were drawing a picture, your first bit of your answer would be your line drawing. So if the question is about, how would you assess someone, you want to do a very clear subjective, and then you also want to make sure that you're safe and that you've ticked all the considered boxes. Once you've got that answer, then the way you get more points, or the way you demonstrate that you know a little bit more, is you keep talking. And the things that you might want to talk about then is maybe what you've read, the guidelines that you're aware of, the evidence that's based around. So if you've got a question on arthritis, you need to be aware of all those things. And then finally, if you really want to showcase what you know and really try and stand out from the other candidates, then you want to add the colour. And the colour would be things like knowing what's going on in the trust that you're applying to. Maybe they've got some projects that are pertinent to the question they've asked about. Maybe you've got something about your experience that you want to showcase, a unique selling point for you that you want to add into the question. So think about it. And what we always say is take your time with these questions. So hopefully that gives you a little bit of an overview. Jazz is going to go into some beautiful detail now about MSK specific stuff, but just keep adding those things into the chat and we'll hopefully give you a really, really lovely session. I'll hand over to Jazz.
Amazing, thank you, Nikki. My name's Jazz Dymott. I'm an advanced practitioner at Horder Healthcare. I graduated from the University of Brighton 9 years ago now, I think it was. And yeah, I was lucky enough to have a placement at Horder, and following that applied for a Band 5 job, and the rest is sort of history, as they say. So mostly my experiences within MSK and a little bit of elective orthopaedics on our inpatient ward. Some of you may or may not be aware, but the Horder Healthcare does have a big orthopaedic hospital in Crowborough, as well as the Mackindo in East Grinstead. And we also have coastal sites for outpatient clinics, Eastbourne and Seaford, which is where I am today. So yeah, that's really my background. And I hope today is useful, not just for hopefully giving you confidence to smash the questions on the MSK side of it, but when you eventually see those patients, hopefully this is a good little introduction of the importance of a good assessment and how to manage those patients. We did discuss the other day about how this can be transferred across all the specialities of physio, so it isn't necessarily just MSK related. The basics of obviously of a good assessment, managing as well, be applied across. I'm just going to check everyone can hear me. Hannah or Nikki, you nod so I know that you can hear me. Oh,
yeah, we can hear you.
Okay, cool. Next slide. Thank you, SJ. Right, so I'm going to start off with a little picture. You might have to click this a few times, Sarah Jane. Sorry, there's quite a few bullet points here. I left my husband Tim doing the animation, so yeah, I apologise for that in advance. So yeah, I just thought I'd start with a quote at the bottom, which isn't really news to anyone. By failing to prepare, you are failing to you're preparing to fail. So just touching on what Nikki said at the very beginning, it's really important to spend time reading through the job description and getting an understanding of the trust and the organisation that you're applying to. Lots of those core themes will be very similar across the board, but it's really important that you sort of showcase your strengths here. As physios, we're naturally normally really good problem solvers and have strong interpersonal communication skills. So these are, like Nikki said, good point scoring questions where you can really, show that you're a team player and that you're caring, friendly, all of those really positive things that most physios are anyway. So they're nice and easy ones. Yeah, I've added in that there's a really good podcast, the New Grad Physio. He talks about tips for CV and job applications, so it's worth a look at, and they're all free to listen to. It's really good to keep engaging with the profession while you're, applying and looking for jobs. And I've put on here to sort of practice running through with your friends or family. It might seem a bit cringy, or do it to your dog or whoever's there to listen to, but the more you kind of practice, the easier it becomes. I know myself today, I'm really nervous, almost like I've had an interview because I've never done anything like this before. But the more you do it, the easier it becomes. And I've just written on here about when you have an interview, make sure you're on time, preferably early. I always think back to my interview at the University of Brighton. I was 18. I just literally passed my driving test and it was snowing. It never snows, but it snowed that day. It was sleeting when I left home about 15 minutes away from Eastbourne. By the time I got into Eastbourne, it was proper snow and ice. And anyone that knows where the campus used to be in Meads is super hilly. So I had to sort of abandon my car, shuffle up the hill. And it was quite a stressful preparation to the interview. When I got there, everyone was in suits, really smart. And I was in like a big woolly coat and a hat. Luckily, I'd left enough time. But I think, yeah, that I always think about that when I was writing this presentation. It's really important to build in extra time, plan for your journey, just take any of the stress out that you can, basically. And I know that lots of these things will be probably touching on what was covered yesterday, but it's just a few things that I thought off the top of my head from my experience. Yeah, take a notepad and pen. So some of the questions are a bit longer and you might need to jot them down. And it's totally normal to ask for questions to be repeated. We're not robots. You can't always remember things the first time. Yeah, and I've just said try and take your time with your answer. The more you can think about structure and flow, the more likely you are to get everything in and not miss anything out. And I think it's also important to remember that interviewers are not trying to catch you out. They're not trying to trip you up. They really just want to see that you're safe and that you can clinically reason and work your way through a case, basically. And my final bullet point there, it's okay to say that if you're really unsure, that obviously you would ask a colleague or a senior for their thoughts and support on a case. That's what we do every day. If there's a patient we're a little bit unsure of, my colleagues across the corridor, we're always speaking to each other. So yeah, they're not trying to trip you up, and just take your time working through the questions is probably my best advice. Next slide, SJ. Sorry, this is going to be so awkward. Okay, could probably stop there for just a minute. Thank you. So this is the case study that we're going to be looking at today. The plan of the session is that we'll have a little read of this slide, and I'm going to give you a few minutes to then answer a confidence survey, just to gauge how you feel about answering this sort of question at the moment. And then once we've had our discussion today, we'll come back to this and see if we can review it and if hopefully there's an improvement there. So we're focusing today on this one case study. If there's time, we can potentially cover another one. But we've got a 45-year-old female patient who enjoys local league netball. She presents to MSK clinic with a 3-month history of right knee pain. On referral to our service, her GP arranged an X-ray which shows mild arthritis. Okay, so that's all the information that we're going to go with for now. There's going to be 4 questions on here, and we're going to work through each one individually, pick it apart a little bit and come up with a really good answer. So yeah, question 1 is mainly focusing on our subjective assessment, and feel free to jot these down if you want to, or they will be on the slide, so don't worry too much if not. Second question is your objective, and your third question is about differential diagnosis, and then the fourth is covering treatment. Now, generally, you can probably have any of these questions asked about a case study. You would be unlikely to have all four, but I thought if we went through one case study really thoroughly, and again, a lot of it's transferable to any patient, hopefully that will give us a really good grounding of how to do these MSK questions. So I'll just give you a couple of minutes to, hopefully this works, the Menti link. Yeah, if you can fill that in, that'll be brilliant. So I'll give you, it's 5:15 now, I'll give you till 5:18 just to have a little look at this and be honest. I think it's all anonymous, but it's just really helpful for us to gauge where confidence scores are. Okay. Please do let us know if that isn't working, the QR code or the numbered code there. Looks like there's still a few people joining, so hello, welcome. We've just done the brief introduction and we're just asked you to complete the survey for your confidence scores based on MSK questions at the moment, how you feel answering those. Give you a couple of minutes and then we'll move on. Just give everyone another 30 seconds or so, but please do mention in the chat if that link hasn't worked. I'm going to assume that the silence was positive there and that it did work. The plan for the session now, like I say, we're going to break down each question and talk through it in a little bit more detail. It's not probably going to be that easy for this to be interactive with so many on here today, which is great to have good numbers, but please do use the chat. So there'll be moments where I ask for thoughts or suggestions to the questions, so please do type away. You know, this is not a thing of right or wrong answers. We're just sharing learning essentially. It does look like some people are having issues with the link, but hopefully that's working now. Okay, should I move on, Sarah Jane, do you think? So that should be what you saw on the Menti link. I'm hoping that worked for everybody.
Sorry, I don't know, Jazz, this is Amelia, why it's come up, but we have had responses through, so I'll just take a screenshot and put it in the chat so you can see. But it's a mix between not very, neutral and fairly confident, and we haven't got anyone that's very confident at the moment, so hopefully we can change that in today's session. But I'll just pop a screenshot in the chat.
Amazing, thank you everyone for completing that. That's really helpful. Yeah, so we'll move on then to the first question. Again, I've kept the case study at the top, so if you know, just for everyone's memory. So question one, sorry, yeah, subjectively, what would you be looking for to help you establish where this lady's pain is coming from? And I'm going to give you literally just sort of a minute, 30 seconds to have a think or write down any suggestions that you might have. I've put a little quote at the bottom there. I just thought that was really sweet about physiotherapists having the brain of a scientist, the heart of a humanist, and the hands of an artist. So, you know, we're all pretty good, aren't we? If we can do all of that, that's amazing. Yeah, let's see what we find from this subjective then. What do we want to ask this lady? Okay. Yeah, brilliant. I can see someone's mentioned about 24-hour pattern. Brilliant. Yes, mechanism of injury. This is great, guys. Yep, we're getting some good suggestions on here. Amazing. Okay, this is good. Yep, you're all coming up with some really, really positive suggestions here. I'm liking that. So yeah, if we go on to the next slide, Sarah Jane, sorry. And again, you might have to skip through quite a bit of this. There's quite a lot on here. So maybe hold it there. Thank you. Sorry. Okay, so thinking about our good subjective assessment, this is the basis really of everything that we do as physios, thinking about your must, should and could. And again, it goes back to what Nikki was saying at the very beginning about being safe. So your must is what we have to do to be safe. And your shoulds and coulds are what we sort of see as those extra layers, and if we have extra time with our patient. So yeah, thinking about that is really important. I've just seen a typo there. I will correct that before we resend it out. A few of you mentioned the mechanism of injury. Brilliant. Yes, so we need to find out, when did this patient's pain start? Was there a clear injury? So we know that she plays netball. Did she twist? Did she land awkwardly? And a few of you also mentioned about any popping. Yes, did they hear a pop or a click? Because again, that sort of trauma may indicate that there's been a possible ligament or even cartilage injury compared to a pain that just came on very gradually. Or it might be that someone's increased their exercise lots, or they've got a new job. So it's really important that we find out, when did that pain start, and we can work out what was going on around that. So that gives us a really good basic start point. Okay, and then a few of you also said about the aggravating and easing factors. Yep. Again, this helps us to piece together the source of symptoms, so what we think might be going on with this patient. And really, I always think of the subjective as the most important bit. You shouldn't rush it in an interview or with your patients, because essentially the patient knows their pain best. They're living with it all the time. We want to try and get as much information from them as possible to help us build these hypotheses that we then want to go and test objectively to see if it is that or if it is something else. So it's really, really important. So yeah, we've said about mechanisms of injury, aggravating and easing factors. So for example, if this lady says her pain is worse when she does squatting, or maybe climbing the stairs, or anything where the knee is loaded into flexion, we might be steering towards patellofemoral joint pain. That's just for an example with that one. Yeah, it's always worth speaking about 24-hour pattern, which lots of you said in the chat, which is great. That gives us a clue about if his morning stiffness could be more of an arthritic presentation. We want to find out about the nature of the pain. So we use our body charts, and we want to find out how the patient would describe that pain. Now, we know that pain is subjective to each individual. If it's more of a dull ache, we might be thinking, again, that fits with an arthritic pain. Is it a sharp shooting pain? All of those things help us build up a picture of how this is impacting the patient, essentially. Again, lots of this can be applied to any patient, and we always cover a full health screening. I'm sure lots of you have probably been taught or are aware of what we call threads. I think that might be on the next click, SJ, sorry. And I think we all know to ask this, but I thought it was worth spending a minute or two explaining why each one is so important. We don't just ask questions for the sake of it. We're always trying to ascertain importance from it. So, for example, thyroid, so the T of threads, that can impact healing. So if people have got thyroid problems, they might have delayed healing compared to others in the population. H and R are heart and respiratory problems. So these are more thinking about your assessment. It might impact the position you put a patient in, you know, if they're struggling with their breath, or they, you know, have postural hypertension, for example, it might affect how you're going to assess that patient and how much they can tolerate as well. E is for epilepsy. Again, really important that we know that if anything was to happen in an appointment. A is for anticoagulants. So is your patient on any blood thinners? If so, that might impact, again, bleeding and healing. It's just something that we always consider. The D is for diabetes, which again, we know has impacts with healing, very delayed healing. If this was a spinal patient, again, we know that patients can get diabetic neuropathy. So it's just thinking about these things in the background. Might not be the cause of the symptoms, but they might be contributing to the problem. S is for steroids. So a patient that's had prolonged steroid use, we're always, you know, a little bit wary. Their risk of osteoporosis is higher, which is the OP there on the end of that threads, and CA is cancer. So these are really important questions. It gives us an understanding of a person's health. I suppose with cancer, we are always wary. Our suspicion, our index of suspicion is probably slightly higher for sinister pathology if someone has got a history of that. But it's something we just consider. It again with this knee patient, we're not necessarily thinking that at this point, but it's something to be mindful of. You know, has someone had chemotherapy, radiotherapy? Again, we know that can often cause nerve damage or other issues later on. So it's just something, I can't really stress how important that is to get a thorough history and understanding of this person's health and medications as well. And then we also touch on smoking status and alcohol, again, effects on healing. It's just really important, and their overall well-being, really. A few of you said in the group, which was brilliant, you asked about clicking and locking, which is great. So those special questions for the knee joint specifically, yes, swelling. So initially, if there was an injury, was there swelling? Is there still swelling now? It can indicate that there's still inflammation and that process is still happening in the body. Locking, so true locking is incredibly rare, and sometimes patients will sort of say, yes, I get locking. What they mean is stiffness. So true locking, where you can't move the joint at all and you're having to physically use your arms to move it, that can indicate there's something wrong with the meniscus, so some pathology or injury there. Again, it might just change how we manage the patient if that is happening. And again, lots of you mentioned giving way. Again, that might link with an injury. Was there a twist or a pivot or something where the knee gave way? Might just make us think, is it more of a ligament injury as well? So it's just really important that you ask those questions. I guess to make this relevant to more patients, if it was a spinal patient, you'd obviously be asking your Horder Healthcare questions if appropriate.
Thank you.
Yeah, so all of that's really important. I've also touched on outcome measures. So each trust probably use slightly different outcome measures. Again, although lots of them will be very similar, this is really important because it's a chance to build rapport essentially with your patient. You're finding out a little bit about their attitudes, their beliefs, their goals, what is important to them, what is this pain stopping them doing. You know, if this lady that we're thinking about at the top, if she can't play netball, you know, she's probably not going to be too happy, but that might be something that's really important to her. So from the beginning, if we can focus on what her expectation is or what she wants to be doing, that will really help. And it also helps with discharge planning from the very initial assessment. You know, it's very easy to fall into the trap of seeing people multiple times and not really knowing if they're getting better. Whereas if you have clear outcome measures and you say, look, at the beginning you couldn't do this and now you can achieve it, it's a really nice way of actually one, engaging the patient, and two, proving that what you're doing is working and that the patient is improving. And again, as a bigger picture for the profession as a whole, completing these outcome measures is really, really important. So if you can get it in there in an interview, it's a really good idea because it just shows you're thinking already about the discharge process and getting this patient better, which is ultimately what we want to be doing. Do I have any more notes on that one? I think that's it. Does that all make sense so far? Everyone happy with that question? Yeah. So we'll move. Brilliant. I'm seeing lots of thumbs up. That's great. We'll move on to the next question now. And then I'll give you a minute or two just to type some suggestions in, because that was really, really good to do that. Caroline, I can see your question there. I'm going to leave that with one of my colleagues, Hannah or Nikki, to answer that, if that's okay. So yeah, question 2, we're thinking again about this patient that we've mentioned earlier, 45-year-old female who enjoys local knee netball with 3-month history of knee pain. We've been deliberately quite vague with the information we've given here, but also this is not uncommon for what you might receive on a referral. So it's a good opportunity to open it up a little bit more. But yeah, the question 2, we're going to be thinking about our objective assessment. So what would that look like and what special tests might you do? So I'm going to give you another minute or two just to type those suggestions in the box again, and then we'll go through a really good answer for that. Yeah. Yeah, really good answers coming in. Keep those going. Yeah. Yeah. Cool. Yeah, I'm trying to go through and put my thumbs up, but these are all really good suggestions. Yeah, perfect. I'll give you another 30 seconds on that just to have a think. You don't necessarily have to write it on the chat if you're not sure or you're feeling a bit uncertain, but just have a think. If you were asked that question with this lady that we've described, what would you really want to have a look at? And again, it's thinking about your must, should, and could. So what must you do in that initial assessment, and what must you show in the interview that you have looked at? Okay, cool. So we'll move on to the next slide. Thank you, Sarah Jane. So a good answer for this question, as we said at the very beginning, thinking about the flow and the structure of the question is always really, really good. So what we don't want to do is be jumping around too much. And even when we've got the patient in here, we're all guilty of it, but getting them up and down, thinking, oh, I just want to check that again, trying to make it flow keeps it a bit simpler for everybody. So what I've said in my notes here is just that remember that the assessment of your objective really starts from getting that patient from the waiting room. You're going to be looking at them walking and getting out of the chair. So immediately, our observant brains are sort of taking note of that, if you like. So yeah, a few of you mentioned about watching the gait analysis. Definitely, are they reduced weight bearing on that side? Are they limping? Are they dragging the leg? Yeah, really important. A couple of you mentioned about heat and swelling. Again, that's really good. Any obvious signs of any deformity or inflammation going on there? A few of you mentioned about functional assessment as well. It's really good. So yeah, we want to sort of try and link that to the aggravating factors maybe and see if we can reproduce that patient's pain. So yeah, sit to stand, squat, lunging, hopping if they're younger and a bit more able. Again, this can be applied to any patient if they're a bit more sedentary or a bit more immobile. There's lots that we can do in the chair. So it's just having a look at people's functional ability really is really important. Range of movement and strength. Again, I think a lot of you touched on that. With knee pain, we always, and with anything really, we always think of the joint above and below to rule out as well. So with this, I would definitely want to look at the lady's hip movements as well as her knee and checking her strength generally. Is it massively different to the other side? Yeah, is there anything obvious in that area that we can see? Because again, this is helping us to build our hypothesis and also our treatment plan. So whatever is highlighted from here or anything that we found in our subjective, if the knee's kind of giving way when she's jumping around at netball and she's higher end patient, we know we're going to have to push her a little bit more. We might not necessarily trigger her pain, just getting her out from a chair and doing simple things. Oh, something happening outside the window. Sorry, it sounds like I'm sweeping. It's not open. Sorry. Right. Again, a few of you mentioned about the palpation, which is really, really important. So again, palpating the joint line, is there any obvious tenderness or discomfort there? And special tests, again, a few of you mentioned this. Yeah, definitely you want to, look at ligament testing, McMurray's if the patient can tolerate it, or Sally's in standing. I think it's really important, if you mention these tests, just to be mindful that no test is perfect, and it's much better to have an open mind and treat everything as like a cluster. We group all of our findings together. There isn't really one test with 100% sensitivity or specificity, so it's important that we do it if it's appropriate, but it's knowing the limitations of those tests as well. But yeah, definitely for this lady, you would probably want to do a full ligament check, and McMurray's and Sally's as well. Yeah, so that's really important. You're all coming up with really good, a few of you said about hip and ankle assessment as well. Is this lady massively flat-footed? Because actually that might be contributing to her knee pain. And I think the picture at the bottom tried to summarize that really. This is the question I ask myself all the time. Are you moving poorly because you're in pain, or are you in pain because you're moving poorly? And it's nearly always probably a combination of the two. But again, lots of this can be applied to other joints. Again, the only thing you might add if it was a spinal patient is a full lower limb and or upper limb neurointegrity test, where you look at strength, myotomes, dermatomes, sensation and reflexes, as well as your straight leg raises, upper limb tension tests, any upper motor neuron signs, that type of thing. So what we find here today and what we go through, it can be sort of transferred across the board. This is not just limited to knee patients, all right? So it's the basis of a good assessment pretty much across the board, okay? So yeah, well done. You've all come up with some really good ideas there. I'm just reading this last thing. If from the subjective assessment there is no indication of potential ligament injury. Yeah, so I see that question where you've said about no indication for any ligament injuries during the subjective. If you have time, there's no harm in checking it, but you might not be suspicious of it. If you have time, yes, definitely, I would always check that. Even if a patient hasn't had the locking and they're giving way as such, it might still be relevant. They might have hypermobility, so you always want to check it to the other side as well with that. But yeah, that's like you said about your must, should and could. Must is, got to nail down the basics and the safety stuff. The shoulds and the coulds might come later, or if for example, you run out of time, those are things that you can add into your plan for next time. That's more thinking when you're actually managing the patient rather than an interview. Right. Cool. So we'll go on to the next question. I think it's the next question. Yeah. So now we're thinking differential diagnosis, and I've just written a few things here. Try not to overcomplicate it. Again, no one's trying to trip you up or catch you out. Interviewers really want to see your reasoning and see why you think it's a certain thing. So you think it's this because of that. And as long as you can justify why you think you're steering towards that diagnosis, then that's great. So I'll give you just another sort of minute, 2 minutes, just to type in the box some possible differential diagnosis for our case study. Again, I appreciate it is still a little bit vague and I haven't necessarily answered the questions that we've gone through, but just a couple of suggestions of what you might be thinking at this stage. I've just seen your questions, Sunila, as well on the group. There will be time for questions after this one, so I will go through that in a minute. But with so if you're going for a general Band 5 job, you might actually only have 1 or 2 MSK questions. If you're going for a specific MSK role, then obviously there might be slightly more, but you can probably expect definitely a spinal question is highly likely to be asked, and a peripheral joint as well. So we're focusing obviously on a peripheral joint today. If there's time at the end, we can go through the spinal question as well. I think generally we get that hammered into us quite a lot, and we're quite focused on that. Like I say, a lot of this is transferable across all joints anyway, but we will touch on the spine at the end. It's all right, I'm presenting till about 6, is that all right? great suggestions in this box. That's really good. Yeah, we'll cover some of these in a minute. That's really good. I like your thinking, Caroline. That's good. I'm liking the outside the box thoughts. It's great as long as you can justify it and it all fits. Then 100% you can put that as a differential diagnosis. So I think for this lady, it was probably a little bit, maybe a bit mean, but to add in about the x-ray findings, because this is often what GPs do, that if they're able to, they will just request an x-ray before referring in. And for some pathways, it's required. So it isn't always, the wrong thing to do. But for this lady, I just wanted to indicate that it showed mild arthritis. So, patients might fixate on that or get very concerned, particularly if they're young and active. We know that could be an incidental finding. She could likely have that in the other knee, but she doesn't have any symptoms. So I've put it in there, sort of a red herring. I don't, it's still good. And we're going to talk about the management of arthritis in a bit. But it's good that you've all kind of gone away from that and thought about other things, other structures that could be causing this lady's pain. So I can see a lot of mention about meniscus, patellofemoral pain. Yeah, definitely. So especially if this lady's getting pain with loading and twisting, then it likely could be the patellofemoral joint. And the way we explain that to patients might be that it's to do with how the kneecap moves within the groove, and it can get quite irritated with certain movements. So I definitely agree with a lot of you have said that. Irritation of the meniscus, And Caroline mentioned about ankle instability. So we would know all that through doing sort of a thorough subjective and a full objective, treating the patient holistically, basically. So even if they come in with knee pain, it's just not forgetting to check the ankles and the hips and everything that we've already said about. Good, lots of mentioning about clicking and grinding. So patients will often report clicking and grinding and be quite concerned about it. And again, lots of our role is sometimes reassuring them that we're not too concerned about that. It can be quite normal. It can be air in the joints. We're really concerned if the joint is locking and it's stuck ever, then that's concerning. But clicking on its own is we can reassure patients about that lots of the time. Good. You've also, I really like what Ella Coley mentioned. So she said that she thinks it's patellofemoral pain, and you put why. So if there was aggravating factors like worse on the stairs, and some of you have said about running, jumping, patellar tendinopathy, that's great, because what I can see from that is that you're linking it to a reason why, and that's basically what an interviewer will be looking for. Not that you've just gone, oh, it's OA or it's knee pain. You've actually gone, it could be this because the patient said this. And that's really, really good. As I've said on the slide here, at band 5 level, they're not trying to trip you up. They're not trying to catch you out. Really, it probably is whatever you're thinking first of all is probably a good goer. As long as you can back it up with the reasoning, then be confident with what you're saying. They're not looking to catch you out. Okay. So I think we'll go on to the next slide. I didn't know whether it was worth just touching on. I saw a question somewhere. Sorry, Hannah, did I go into it enough detail where we said about if there was no subjective sort of mention of ligament stuff? If there's time, it's still worth checking. You've done probably more interviewing people than me.
Yeah, I think it's always worth kind of mentioning it as a possibility and maybe justifying why you wouldn't do it in this instance. If you're not suspicious of it, if you're not suspecting of it, if clinically it doesn't fit that pattern, all the whys that you add or all the justification helps you to kind of show you're working. That's how I always remember my maths teacher kind of saying in my ear, we can see you've got the answer, but where's the working out? And it's that why is your clinical reasoning, that's your working out. And actually as an interviewer, it's really helpful to kind of to understand your thought process and how you're coming to that conclusion.
Yeah, definitely. Thank you. That's really helpful. And there was another one I think I was going to get you to step in on. Let me just double check. Oh yeah, someone mentioned about what sort of other joint questions can we expect, and I sort of briefly said about you know, it's probably good to prepare for a spine question. I think we do prepare for that. We're all quite well drilled on that almost. And then a peripheral joint as well. Like I say, if you're applying for a rotational job, you might not have many MSK questions. It might just be one or two. So you really want to get as much of your clinical reasoning and your understanding out as possible. If you're going just for an MSK job, then likelihood is you're going to have a couple more.
I think always there's going to be something that requires some form of escalation, you know, whether it's a call to a specialist or a urgent referral or a send to A&E. There's always going to be a curveball in there somewhere, because and also there's also going to be scenarios where we're looking that you're going to ask someone or seek help and not just try and manage it on your own as a new grad physio. We want to see that you will go and ask, because it obviously from a safety perspective that's really important. So it's absolutely okay for you to say that in your interview, and we would want to hear it, because we don't want anyone working in silo kind of dangerously. It's a real demonstration of being a safe practitioner, is that I might suspect this and I might just check in with my colleague. That's a really important factor to consider.
100%, and I did put that on the first slide if any of you missed that at the beginning, but it is okay to say to an interviewer that if you are unsure or you have got a challenging patient, that you would ask your colleague for support or to run it through with them, because that's what happens in everyday life. Me and my colleagues are constantly in and out of our rooms to each other asking just for support, and often we do have the answer, like Hannah said, but we just want to run through our workings out, or we just want to check that they would do the same thing. It's really important as a band 5 that you understand your scope of practice. You don't take on the world. If there is something that is too much, that you do ask for support. And there's absolutely no shame in saying that in the interview. In fact, like Hannah said, they want to see you doing that. So yeah, that is mentioned on the first slide if anyone did miss that earlier.
And you've just demonstrated doing it, Jazz, because you asked me a question. Perfect.
So yeah, question 4, we're going to just touch on, again, thinking about our netball lady, what advice and treatment might we suggest? Now, again, I know a lot of this will depend on what we've found in the previous questions, but based on what we've sort of chatted through and the possibilities, it would be good to get some thoughts in the chat about what advice and treatment you might suggest, and extra points if you can link this to any evidence. That's going to be great. Nice guidelines, that sort of thing. But yeah, let's have a few thoughts in the chat for a minute or two, and then we'll go through this question here. Mm-hmm. Yeah. Sunila, I've just seen your question, which is a really good point, and again, we'll touch on that at the end of the section. I think that's a really good point, just to clarify that you might have not been 100% on the diagnosis, as long as you can reason why you're there, and then giving appropriate advice, as long as it's not unsafe. You wouldn't necessarily lose points for that, no. But that is a really good question, and I'm going to try and pin it so that we can come back to it.
I think it's also important as well, isn't it, Jazz, to have a mix of possible diagnoses. So it's never pinning down to one. There's always going to be more than one possible diagnosis, and that's how it should work in clinical practice. You know, you've got maybe a clearer or more likely diagnosis, but there's always going to be the potential for it to be something else. So you'll probably, if you don't get the key one, you'll probably fall on one of the others. Again, as Jazz said, as long as you can justify it and reason it, and maybe kind of allude to the fact that it could also be these things, but you think it's this because of, that would be accepted, definitely.
Definitely. And also with everything we do, it is a bit of trial and error. So it might be that you say, you know, you think it's this because of this, and therefore we're going to treat it like this. However, if I see the patient again and it's got worse, I'm going to reassess, I'm going to rethink, and then maybe I'll steer towards a different possibility and a different treatment. So it's, you know, like Hannah said, we're not really going down one rabbit hole. It's always thinking of what other things could be going on, because we know that pain is so multifactorial. It's very, very rarely going to be one thing that's causing it. You know, it's other health issues, it's stress, it's diet, you know, other psychosocial factors that are playing a part as well. So yeah, I think that was a really good question actually, because there isn't essentially a wrong answer as long as you can justify it and make adjustments, really. Good. Good. There's some really good answers on here. This is brilliant. Good. I've seen mentions about flare-ups again. Yep. So we're going to go through all of this in a minute. It's really, really good. Great. Yeah. Thank you guys for being interactive on the chat. That's really, really useful to see your thoughts on this. And yeah, you're all coming up with really good suggestions. So let's go through a sort of a good answer for this as a whole. Like I say, depending on what we found from our subjective and objective, we're going to link it to the NICE guidelines if we did think it was osteoarthritis, for example, and really pushing that exercise is the gold standard treatment for this. Really reassuring the patient that, you know, we're not concerned about the X-ray findings and that physiotherapy can help patients like this. And considering her age wouldn't be, you know, appropriate for any invasive surgery or anything like that, we are thinking conservative management for this patient. I've put on here about signposting or education around other resources. So in our area, we have 1UE Sussex, which is a free organisation where they offer adult weight management, health coaching, smoking cessation. So it's something that we can offer to patients as well as our services, and it's just about making every contact count, really. So making sure that we're covering all areas and treating the patient holistically, thinking about health and well-being, not just focusing on the one problem there. So yeah, definitely for this lady, if she's quite active and independent, you know, we could be looking to give her a program and maybe not seeing her every week, for example, because that's a question you might get asked, is how often would you see this patient? There's nothing to indicate that she needs reliance on regular treatment. So we would want to spread it out, and linking that to the research that we know it's going to take weeks, months to see real improvements in strength training. Just having that conversation with the patient from the beginning, really, to set that expectation. Yeah, for example, in our area, we do escape pain classes for arthritis, so it's worth investigating the areas that you're going to be applying for or looking for jobs in. What do they offer patients with arthritis, or what does the trust do? Do they do classes? Do they do virtual sessions? There's all sorts that people offer, and a lot of the resources for this are online. So again, you can signpost a patient to that to look at in their own time. There's lots of chronic pain websites, podcasts, again, that I'm always sending patients to look at. Again, if they're taking an active role in their recovery and they want to learn more about it, there's so much out there for patients. So yeah, definitely signposting, and definitely addressing things like weight loss if appropriate with patients. And again, we always use that nice analogy that if you lose a pound of weight, it's 4 or 5 pounds off your knees because of the way we walk. And it's just trying to get patients to buy into it, because it can be an awkward or uncomfortable conversation, but we do need to have those conversations to make sure we're managing patients best we can, really. What else did I want to say here? Yeah, linking back to my pictures on the other slide, you know, can she go swimming or do some cycling or something non-weight bearing for a few weeks to let the knee settle down? It's thinking about all those other things as well. If she's quite active minded and wants to be doing things, maybe modifying it. Lots of you said that actually reducing aggravating factors and gradually loading the knee, that's all brilliant. All of those things are little ticks. Yeah, I think every suggestion that you've said on the box has been correct, you know, with this management of this patient. So I think it's about trusting yourself and thinking, like I said, try it, see how we get on. If it doesn't improve, we're going to reassess the patient. We're going to see how they're getting on. But these generic sort of treatment plans, linking it to nice guidelines, you know, and sort of avoiding reliance on things like injections and keeping things like surgery for those specific patients that meet the right criteria. Yeah, I'm glad to see actually none of you have mentioned surgery or, you know, injections. That's really good. You can see there's mention of fibromyalgia here as well. Yeah, so I can see like it's all firing, all the cylinders are firing. It's great. Just reading what Hannah said there. Yeah, as Hannah said, ideal for every speciality, not just MSK. So it is thinking about how can we have an impact on this patient's life? How can we support them with making healthier choices? Basically, it's really, really important. I am going to stop talking there just for a minute and maybe let someone else step in if there's anything that you want to add on this. Again, Hannah is my line manager, so she's done lots of interviews. Yeah, is there anything else for that slide?
We were just going to talk about some of the Q&As that have come up, just so that people are aware of the kind of questions. There was a question about what kind of medications do we need to be aware of. The answer is really a few things. Medications might tell you how much pain someone's in. Also, patients can be terrible historians, or they might not understand they're taking something for a reason. So you might have asked them about cardiac problems and then they're on a blood pressure medication. So it's another way of checking your past medical questions. The other thing as well is there might be a drug interaction. It's very common that we're the first people to see things. Sometimes someone's taking a paracetamol with a cocodamol and don't realise they're taking 2 lots of something they shouldn't be. Also, things might have an effect on healing as well. So, you know, some of the anticoagulants might change how much hands-on or soft tissue therapy you do with someone. So it is important to know about the medications and just double check with the patient. Another question was, what is the clinical significance of special questions? I mean, special questions are joint-specific questions that sometimes lead you towards considering different particular structures. They're also really important from a safety perspective, especially, you know, in sort of spinal areas as well. So it is important to know your special questions and know why you're asking them and what the relevance of them are. So that was another one. Any example of outcome measures? We sort of said, yeah, there's lots of outcome measures. Outcome measures measure lots of different things, but be aware of the types of outcome measures. Some will look at function, some will look at quality of life, some will be specific to a joint, some will be specific to function. So just know about some of them for each of the joints so that you can just apply it and know what's used in the trust that you're going to be working on or you're trying to get a job in, because that's really, really important. There was a question about, is it worth discussing relevant research around assessment validities, i.e. how useful palpation is or isn't for certain differentials? And I think Hannah and I both said, actually, this is a question that you would sort of add in once you've got your bare bones down, once you've been safe, once you've got your you know, this would be an extra bit that might give you an extra few points when we're talking about point scoring or talking about, you know, adding colour to your picture. So it would be something that might help you to stand out. So that was sort of it. The only last question was, if someone's given 20 minutes for a practical subjective and objective, how would you split it? I mean, clinically, it depends, very much depends on what you're getting. But like Jazz said, you know, if it is an interview situation, you want to make sure that you've got enough information that will guide you towards your objective, but also that you've covered things. If you don't talk about your objective at all, you've missed those points. So you need to be able to say both. That was pretty much from the Q&A.
Brilliant. Yeah, thank you, Nikki. They're really good points. I mean, for example, like in our service, the outcome measures that we use are EQ5D and PSFS. It might be worth just having a look at some of those if you hadn't come across them in your MSK placements, just to familiarise yourself. But essentially, a patient documents a task that they're struggling with and has to put a score in, and then we, you know, come back to that and compare that as we see the patient throughout, and we use that as part of the discharge planning as well. So yeah, that's just something to be aware of, really. Yeah, I'm just going to leave this slide on here. This was one of Amelia's slides from the CSP, just with a few resources of the graduate support that's out there at the moment, we know it's a difficult time, and there's just a few links about finding jobs, preparing for interviews. It's a really good resource, so please do check this out, and yeah, I highly recommend you have a read through this as well.
Perfect. So, hi, I'm Claire. I'm from the CSP, and so yeah, absolutely, like Jazz just said, please do click on the QR code, or I've popped in the chat a link to all the resources. Do have a look. There's loads of really useful stuff there to help you to prepare for your interviews and be thinking about how you can thrive in the workplace. So do take a look. If we go next slide, Jazz, brilliant. And just to say, this is a series, so anyone who's attended tonight, the recording from yesterday will be available very soon, but we do have our next one already in the diary for Wednesday the 3rd of December, and that is management of the acutely unwell patient. And we have also now got confirmation for one around neuro, and we're hoping also to bring in one around fragility. So it's evolving, so keep an eye. And we go for next slide, and I'm just going to bring Sarah Jane back in just to see if there's any last minute thoughts or points that you'd like to add. And I'll just get everybody, if you wouldn't mind, to complete this Menti. We really want to shape these sessions so they work really well for you. So yeah, do have a little look, put your thoughts down on there, and it will really help us to shape and make them as useful as possible for the future sessions. So SJ, just pass to you to finish.
Thanks, Claire. So as Claire mentioned, do please fill in the feedback form. We'll also follow up with you just to see if there's any other sessions you would like us to run. We're hoping these are beneficial and that you are finding them useful, but do let us know if there are any other areas you'd like us to focus on as well. And we will be sharing that these have been so well attended across all the regions. So we will look to the other regions to maybe also look to putting on some supporting events as well. And Amelia has dropped in the chat, our Southwest regional neighbours are also doing a drop-in next week, or the week after, Tuesday the 25th of November. So do have a go. If you can go to that one, please do think about going along as well. We'll pop the link in for the next webinar for you as well, Jess, no worries. But thank you so much for taking your time out to come tonight. I hope you found it really helpful. A huge thank you to Jazz, Nikki and Hannah for managing this one. It's been great. I've learned lots. You reminded me of loads of things. Thank you, everyone.
Just suddenly remembered we didn't do the end of session sort of confidence scores. I don't know if it's going to be too late now, but or if that's part of this Menti here. I wasn't sure.
It is part of the Menti, so we can have a look at that after. Thank you.
I really hope it's been useful, and like I say, not just for interviews, but also managing those patients as well when you inevitably get the job, because you've all got all the answers on the chat.
Absolutely. Well said, Jazz.